Hello and good morning. Today we're going to discuss thyrotoxicosis and hyperthyroidism. We'll mainly discuss Graves' disease, its clinical features, its pathology, and its treatment. So let's briefly discuss the difference between hyperthyroidism and thyrotoxicosis. There is increased production of thyroid hormones in hyperthyroidism and thyrotoxicosis with decreased TSH levels. So what's hyperthyroidism? In hyperthyroidism, thyroid gland produces increased thyroid hormone, and in thyrotoxicosis, there is increased circulating thyroid hormones, but regardless of the source, it may be a different source other than the thyroid gland. So in thyrotoxicosis, there is increased thyroid hormone with or without increased thyroid hormone synthesis from the thyroid gland. Now, causes of the hyperthyroidism. In hyperthyroidism, increased thyroid activity produces thyroid hormone, and the causes include Graves' disease, toxic multinodular goiter, and toxic adenoma or heart nodule. This is causes of hyperthyroidism. Now, thyrotoxicosis. Thyrotoxicosis with hyperthyroidism. This include all the above causes of hyperthyroidism, the Graves' disease, toxic multinodular goiter, toxic adenoma, and also dominant TSH receptor stimulation. It also includes a pituitary gland producing TSH due to a TSH secreting adenoma. In pituitary hyperthyroidism, there is increased TSH and increased thyroxine. So both are increased. The only condition where both TSH and thyroxine are increased. And third cause with thyrotoxicosis with hyperthyroidism is a tumor, stroma ovarii, in the ovary that produces, there is HCG producing ovarian tumor that causes thyrotoxicosis. Now we go to the thyrotoxicosis without hyperthyroidism. These include the thyrotoxicosis factitia due to excessive ingestion of thyroxine, or it may be due to subacute thyroiditis. In acute phase of thyroiditis, there is thyrotoxicosis, increased thyroid production, and a amiodarone, the drug, which has significantly high levels of iodine that stimulate thyroid to produce thyroxine. And what's the most common form of thyrotoxicosis? That's increased intake of levothyroxine or thyrotoxicosis factitia. Now, the treatment of hyperthyroidism is the systemic relief, antithyroid drugs, or radioactive iodine uptake. Now, let's discuss the Graves' disease. In Graves' disease is the most common cause of thyrotoxicosis and accounts for 60 to 80% of cases of thyrotoxicosis. The second most common cause being toxic multinodular goiter. So, how is the gross appearance of thyroid gland in Graves' disease? Thyroid is diffusely enlarged to 2 to 3 times of its size and is firm in consistency, and there is a trill or bruit over the thyroid gland. Microscopically, there is follicular hyperplasia and cell scalloping because of the colloid reabsorption, because of the hyperactivity or overactivity. Colloid is used excessively, so colloid gets reduced in amount and cell collapse. There is patchy lymphocytic infiltration, and also there is there are follicular cells with increased eosinic cytoplasm. So this was the gross pathology and microscopic pathology of the Graves' disease. Now, autoimmunity. The autoimmune causes the autoimmunity, the TSI antibodies activate the TSH receptor. The TSI stimulatory immunoglobulin antibodies that attach to the TSH receptors and activate it to produce increased thyroid hormone. Now, pathogenesis of the Graves' disease. It may be increased iodine, autoimmune, may antibodies, TPO antibodies, or TSI antibodies I just mentioned. Genetic causes of the Graves' disease is twins. Monozygotic twin concordance rate is 20 to 30%, and in dizygotic twins, the concordance rate for the Graves' disease is less than 5%. So much more in monozygotic twin, but not that much in the dizygotic twin. Polymorphism may also cause it. HLA-DR and CTLA4 are also involved in that. Stress also causes Graves' disease, and in the postmortem period, 3 to 6 months after parturition, it may cause Graves' disease, and there is a threefold increase in the Graves' disease in postpartum period compared to the normal women. Now we go to the in the increase in iodine. Increased iodine, excessive iodine may precipitate hyperthyroidism. It may also cause hypothyroidism. If you see the Wolff-Chaikoff effect, autoregulation by low iodine intake stimulates the sodium iodide sympathers that traps the iodine and inhibit it also. That traps the iodine. And excessive intake of iodine also causes uh, thyrotoxicosis or hyperthyroidism. I already explained in amongst the autoimmune causes, TPO antibodies occur in 80% of cases. And TSI antibodies, they attach to the TSH receptor, stimulate, causing increased thyroxine. TSI antibodies, they can cross the placenta and they cause neonatal thyrotoxicosis. And then we have, let me check, what did I miss? Postpartum. Smoking is a minor risk factor. What's apathetic thyrotoxicosis? Apathetic thyrotoxicosis occurs in elderly and is may be mistaken for depression, and our symptoms are masked and subtle, and there may be only features may be fatigue and weight loss. Now, clinical features of the Graves' disease. It may be increased metabolic activity, increased metabolic rate, increased nitrogen excretion, increased catabolism, and weight loss. Increased metabolic activity also causes myopathy, especially proximal myopathy. So, muscle damage causing hypercalcemia, hypercalciuria, and hyperuricemia, and increased urinary excretion of uric acid. Because of the cell damage, there is decreased hypokalemic periodic paralysis because this most abundant intracellular electrolyte is potassium. So when cell damage potassium is lost, it causes hypokalemic periodic paralysis. And because of the muscle damage, there is hypercalcemia, bone loss from the bone. Calcium loss from the bone causes osteopenia. So bone resorption causing osteopenia. In the cardiovascular system, most common feature is a sinus tachycardia, but the most dangerous is atrial fibrillation that forms a mural thrombus. I'll discuss mural thrombus in a moment. So that mural thrombus may cause a stroke, and the drugs to prevent it are comedine group warfarin. Access for warfarin toxicity, the antidote is vitamin K and protamine sulfase and also the surface substances like fresh frozen plasma. And in the CN, in the nervous system, it causes hyperactivity, hyperreflexia, nervousness, irritability, and fine tremors. Right. So, what's the treatment of this tremulousness and sweating? The treatment for the tremulousness is sympathectomy because thyroid increases the activity of the sympathetic substances, or it may be treated with beta blockers or propranolol. Okay, as I told, tachycardia is most common rhythm disturbance, but most dangerous is atrial fibrillation. Also, there is bounding pulse, wide pulse pressure, and high cardiac output. So what happens in hyperthyroidism that it causes hypercoagulable states, which may cause deep vein thrombosis of the upper extremity. So deep vein thrombosis of the upper extremity may be life-threatening. So these are the arteries which have the result of atrial fibrillation, that is thrombus or microembolisms or thromboembolisms, also in the heart. So the atrial fibrillation that causes the formation of a mural thrombus that causes a stroke. So what's a mural thrombus? Is a blood clot attached to the arterial wall or a cavity can decrease the blood flow to that part and completely cut off the blood supply that leads to the tissue damage. So 35% of the patient with atrial fibrillation have a stroke. So a high number. 35% with atrial fibrillation have a stroke. There is thromboembolism. And in a small blood vessel, atrial fibrillation increases the risk of a stroke by five folds. Now, treatment of this atrial fibrillation is comedine group of warfarin for anticoagulation in atrial fibrillation. And on warfarin, the INR therapeutic level is 2 to 3, and it should be given for at least for 3 months. The antidote for warfarin is vitamin K, fresh frozen plasma, prothrombin, recombinant factor, or protamine sulfase. So the normal INR is 1.1, and the uh, therapeutic range for patient on warfarin is 2 to 3. But at an INR of 4.9, it causes bleeding. Normal prothrombin time is 10 to 14 seconds. So INR is the ratio of prothrombin time of the patient divided by the normal prothrombin time. The normal prothrombin time being 10 to 14 seconds. Now, the other causes, other clinical features are pulmonary edema, onycholysis, and increased blood sugar. Why increased blood sugar? Because of increased carbohydrate absorption from GIT, and also because of increased epinephrine sympathetic activity, cyclic AMP increase that causes glycogenolysis, that causes hyperglycemia. But glycogenolysis causes depletion of glycogen in the liver. Glycogen is protected to liver, so it causes liver damage, decrease in glycogen in the liver. Also, there is impaired sexual function, impotency, amenorrhea, oligomenorrhea, menorrhagia, and gynecomastia as well. And also, it may have thyroid dermopathy. Thyroid dermopathy occurs in 5% of patients with ophthalmopathy. And what's the most frequent site of thyroid dermopathy is the lower leg, but it may involve whole lower leg. And the typical lesion is a non-inflamed indurated plaque, non-inflamed indurated plaque, and it makes the skin orange in appearance. Laboratory evaluation. A normal TSH excludes the grave disease. Only one test. TSH if normal, then it excludes out the Graves disease, right? And otherwise, in grave disease, the other findings are free T4, T3 increase and TSH decrease, and there are TSI antibodies and TPO antibodies are also present. Let's see. Okay. Now, and then we have see all these investigation laboratory features. Everything increased. T3, T4, radioactive iodine uptake, and free thyroxine index, and but only thing that is decreased is TSH. Okay, if TSH is decreased and unbound increase in thyroid hormone plus the sign symptom of Graves' disease, then it's Graves' disease. If sign symptoms are not present, it's a toxic multinodular goiter. Next condition, if there is TSH is decreased but T4 is normal, then measure T3. And if T3 is increased, then it's T3 thyrotoxicosis because T3 thyrotoxicosis occurs in 3 to 5% of the patient. But if TSH is decreased and T3 is also normal, T4 be also normal, then it's subclinical hyperthyroidism. Follow it in 6 weeks' time, 6 to 12 weeks. Then we have a radioactive iodine uptake. There is uniformly increased radioactive iodine in grave disease by the thyroid gland. See here, it's a uniformly increased uptake of the radioactive iodine by the gland. Compare it with the other disorders that are like cold nodule that has decreased radioactive iodine uptake. But this grave disease is increased. And if you compare it to the toxic multinodular, which has both hot and cold nodules, the hot nodule also takes increased radioactive iodine. Like here, hot nodule takes more, but thyroiditis takes decreased radioactive iodine, also malignancy, right? So the condition that take decreased radioactive iodine are cold nodule, destructive thyroiditis, factitious thyroiditis, factitious thyrotoxicosis, malignancy. And also in hot nodule, if you see these hot nodules here, this has increased radioactive iodine, but rest of the gland, this is a hot nodule, so rest of the gland has decreased radioactive iodine uptake. So I put it in a red, increase uptake by the hot nodule, but remaining gland has a decreased radioactive iodine uptake. What about pituitary adenoma secreting TSH? It has a diffuse goiter also. It may be converted to multinodular goiter, toxic. There is increased uptake of radioactive iodine. This is the only condition where pituitary TSH producing pituitary adenoma where we have both increased TSH and increased thyroid hormone production. Other positive tests are increased serum bilirubin because of the liver damage, because decrease in glycogen in the liver, glycogenolysis causes liver damage, so increase liver enzyme, and there is microcytic anemia or thrombocytopenia as well. And then the differential diagnosis is 3P: panic attack, psychosis, pheochromocytoma, and also weight loss associated with malignancy should be included in the differential diagnosis of the Graves' disease. Now, treatment of the Graves' disease: antithyroid drugs, number two, radioactive iodine, and number three, thyroidectomy. Now, amongst the antithyroid drugs, we have two groups, thiazolamides and thiocyanate. Thiocyanate inhibit the sodium iodide synthetase, and they are toxic to the tissues, and they decrease the iodine trapping, and so they are taken off the market because of the toxicity. The antidote is sodium. The example of this is sodium nitroprusside, and treatment for the toxicity of sodium nitroprusside or thiocyanate is sodium nitrite. The other group, thioramide, includes propylthiouracil, carbimazole, and methimazole. Methimazole is a metabolite of carbimazole. The propylthiouracil, what does it do? It decreases the thyroid hormone synthesis. It decreases the deiodination of T4 to T3 because T4 is converted to T3 by deiodination, and T3 is the physiologically active form. So there is decreased deiodination, so T4 is not converted to T3. It's also used prior to the radioactive iodine treatment. Now, thyroid function test. When do we do thyroid function test? When the patient on antithyroid drug every month, 3 to 4 weeks. And when does the patient become euthyroid? In 2 months. And when a maximum remission rates are achieved? In 2 years. So thyroid function test done every month, and patient become euthyroid in 2 months, and high maximum remission occur in 2 years. So 1 month, every month, thyroid function test, euthyroid in 2 months, and maximum remission in 2 years. And does TSH provide sensitive index? No, because it's suppressed. So it doesn't provide a sensitive index for the uh, therapy, to monitor the therapy. Why these drugs may be given with L-thyroxine may be added to antithyroid drugs because they may cause hypothyroidism. To prevent the drug-induced hypothyroidism, L-thyroxine may be added to antithyroid drugs. How many patients develop hypothyroidism after treatment? They develop 15% of the patient in 10 to 15 years. 10% in 10 years, they may develop hypothyroidism. And what are the side effects of antithyroid drugs? It may be a major side effect or a minor side effect. So the major side effects, if they occur, then you stop the antithyroid drugs. And what are those major side effects? The mnemonics is ASH. A for agranulocytosis, S for SLE-like syndrome, and H for hepatic damage or hepatitis. So these are the major side effects of antithyroid drugs: agranulocytosis, SLE-like syndrome, and hepatitis. So the features of agranulocytosis are fever with sore throat and mouth ulcer, very important, and also the granulocyte count will be low in blood testing. The minor side effects are rash, urticaria, fever, and arthralgia. And if there is relapse after antithyroid drugs, then what is the treatment? It's thyroidectomy, subtotal or neototal thyroidectomy, and propranolol is given to control the adrenergic symptoms. And then we go to the radioiodine treatment. Radioiodine treatment. Hang on a second. The radioactive iodine destroys the hyperactive thyroid cells more than the normal cells. In fact, it doesn't have much effect on normal thyroid cell, but it destroys the hyperactive thyroid cells and is concentrated more in those hyperactive thyroid cells. So, how to start the radioactive iodine treatment? There, we have to use prior anti-thyroid drugs 1 month before radiotherapy. Why do we use it, the anti-thyroid drug, before starting the radioiodine treatment? To decrease the thyrotoxic crisis. When should anti-thyroid drugs be stopped? Before radioactive iodine treatment is started. Carbimazole or methimazole is stopped 3 days prior to radioactive iodine treatment. Why? To optimize sorry, to optimize iodine uptake. And propylurothiazole is stopped much few weeks before the radioactive iodine treatment. Amongst these antithyroid drugs, methimazole is quick acting and has fewer side effects than propylthyroxine. What's the contraindications to radioactive iodine treatment? The absolute contraindications and relative. Pregnancy and lactation are the absolute contraindications to radioactive iodine treatment. And the relative contraindications to radioactive iodine treatment are severe ophthalmopathy, and the treatment for ophthalmopathy is steroids. The other relative contraindication to radioactive iodine treatment are bone marrow depression, pulmonary fibrosis, and cancer, because cancer cells don't take the radioactive iodine. And what are the complications of radioactive iodine treatment? A thyroid storm. So, to prevent a thyroid storm, a prior anti-thyroid drugs are given. No pregnancy or lactation for few months, probably 6 months, almost 6 months after radioactive iodine treatment. No pregnancy or lactation, okay, in 6 months. Surgery, that's a definite treatment. Indication for surgery, a large goiter in a young patient. And number two, if there is a relapse after anti-thyroid drug. And the thyroidectomy may be done subtotal or near total. And which medication is given prior to surgery? Potassium iodide. Potassium iodide is given prior to thyroidectomy. Why? To avoid thyrotoxic crisis, reduce vascularity, and to reduce the recurrence rate, which is less than 2%. So, potassium iodide prior to surgery. Complication of surgery, bleeding, infection, laryngeal edema, hypoparathyroidism, because all the four parathyroid glands are attached posterior surface of the thyroid gland. And surgery may also cause damage to the recurrent laryngeal nerve. What's the treatment in pregnancy then? The treatment in pregnancy is propylthyroxine. The propylthyroxine has has relatively low transplacental transfer and blocks the conversion of T4 to T3, as I already explained earlier. And why propylthyroxine may be stopped in third trimester? Because TSI is decreased in third trimester of pregnancy, so propylthyroxine is reduced in that. So that's the end for the day, and it's about half an hour time. So next we'll do later. Okay. So so far right now it's over. Thank you and bye.